Okay, hello everyone. Welcome to this brief interview about our next journal club on November 14. On this opportunity, we will discuss esophagitis after bariatric surgery. This paper published last October in our obesity surgery journal. It's my pleasure to introduce you the first author, Dr. Barham Abu Dayyeh from Mayo Clinic. He's a gastroenterologist, a specialist in bariatric endoscopy and endoscopy management of post-bariatric surgery complications. Welcome, Barham.
Thank you, Pedro. I appreciate the opportunity.
Okay, now tell us why you conducted this study and what was the most relevant finding?
Yes, so we conducted the study as to better define the issue of reflux after bariatric surgery. As you know, this is a timely topic, and there's a lot of interest as we are giving bariatric procedure to younger and younger cohorts to see what's the magnitude of the problem in the long term. However, the literature has some limitation in that the definition of what constitute GERD has been based on symptoms and quality of life questionnaires and GERD-specific questionnaires. So we decided to take a newer approach or a more objective approach about the problem. And since we do lots of endoscopy on bariatric patients, we decided to use esophagitis as an objective measure of reflux, and we decided to look at a prospectively maintained database in a retrospective fashion to evaluate the incidence of esophagitis after two of the most common bariatric surgeries. One is the sleeve gastrectomy and the other one is the Roux gastric bypass. Then we did a sub-study of physiology compared to an obese cohort to define the physiology using manometry. So the biggest findings that we have is that the incidence of reflux esophagitis is higher after sleeve gastrectomy. It was about 37.9%, though the incidence was not negligible after Roux gastric bypass at 17.6%. This persisted after multiple adjustment to confounders, including PPI use and hiatal hernias in a logistic regression model. Then when we did a case match cohort where we compared the incidence of esophagitis to a pre-bariatric surgery cohort, we found that the incidence of esophagitis was higher than pre-bariatric surgery cohort for sleeve gastrectomy, and the physiology is different in that the resting lower esophageal pressures were lower after sleeve gastrectomy, and the esophageal squeeze, what we measure as the DCI or distal contractility index, was lower after sleeve gastrectomy compared to a pre-surgical obese cohort.
Let me ask you, after this study in your bariatric surgery department, have you changed the indication for different types of surgery?
So we're now very careful about selecting the right patient for sleeve gastrectomy. We continue to be a high volume Roux gastric bypass center here. So we do offer the sleeve gastrectomy and we think it's a good surgery, but we are selective. That means if patients have pre or known GERD, then we try to counsel them about Roux gastric bypass. And now we spend more time defining the GE junction anatomy and physiology using endoscopy and physiological measures such as the endoflip and the high resolution manometry. So patients with lax GE junctions based on these measures or larger hiatal hernia, then we counsel more toward Roux gastric bypass, but we still offer both procedures at the Mayo Clinic.
Perfect. So do you consider the upper endoscopy previous to every bariatric surgery mandatory?
I mean, people somewhat have different opinions about this. In my mind, yes, absolutely, it's a mandatory because now we could use upper endoscopy to not only anatomically and physiologically classifies the GE junction or the barrier for reflux prior to bariatric surgery in order to better plan the operation. We also use it to look for undiagnosed Barrett's esophagus or even early cancer prior to surgery. So I think upper endoscopy is mandatory before bariatric surgery.
Perfect. Yeah, according with this result, will you contraindicate the sleeve gastrectomy in some cases?
Yes, if you have known GERD that's poorly controlled on medication, or you have then I think, or you have Barrett's esophagus, both of these are relative contraindications. If you have Barrett's esophagus with high-grade dysplasia, this should be an absolute contraindication, in my opinion. But right now, this is still a gray area, and I think more data and more prospective data is going to help us define the spectrum of contraindications based on reflux.
And what do you consider the upper endoscopy follow-up necessary?
After bariatric surgery, you mean?
Yeah, after Roux-en-Y or a sleeve gastrectomy.
Yes, so after Roux-en-Y, I think it's necessary to evaluate the status of how the body is responding to the alteration in anatomy. Most of esophagitis we know is asymptomatic, so relying on the patient's symptoms is suboptimal in order to define and follow the problem. So I think at least one upper endoscopy at 6 months to a year after bariatric surgery to define the new baseline is a good idea, and further surveillance is guided by symptoms and the finding on the upper endoscopy.
Well, perfect. The last question, what are the pathophysiology mechanisms for GERD and Barrett's esophagus after Roux-en-Y?
Yes, which that's a very interesting area, because as you know, traditionally speaking, people were thinking GERD or Roux-en-Y gastric bypass is a cure for reflux. We know now that the pouch or the residual pouch have still parietal cell function, and that does produce acid. And now we're just publishing or just submitted another paper that showed that the reflux after Roux-en-Y gastric bypass is either weakly acidic or alkaline. That means there's still reflux, but it's not necessarily fully acidic as we see after sleeve gastrectomy. So it's a weakly acidic alkaline reflux. It depends on the residual pouch. It depends on the diameter of the gastroduodenal stoma, and that depends on the length of the rulum, which all factors that contribute to reflux after a gastric bypass.
Okay, perfect. What is your last message to our professional bariatric community?
The message is we don't want to. It's not this. This research is geared toward better defining the problem, both in as far as magnitude using objective measures as esophagitis, and as well as physiology to better define what's going on in response to these alterations to the GI tract. I think we need better studies that's more prospective down the line, and we need better screening modalities to evaluate the physiology at baseline in order to better inform the surgical choice. And I think we're going to see activity as far as research in both direction, better define the issues as far as reflux after bariatric surgery, and then better using tools to better predict the outcomes at baseline, so you could counsel the patients for different procedures based on their physiology rather than just based on clinical history.
Perfect. Thank you very much, Barham, for this brief interview. And we hope see you all of you on November 14th for our journal club. Thank you very much.
Thank you, Pedro. Thank you.
Bye-bye.